whenever there is contrast or any controversies here, you're following the final word from infection control. Yet again, as I whenever there is contrast or any controversies here, you're following the final word from infection control. Yet again, as I always say, the guidelines are always there to help you to decide what should be done. But Odell is a clinical case. It exactly puts you in the form of history, in the form of clinical situation, just the way SBQ is going to be fabricated, SBQ is going to be asked in the exam. So no matter how many guidelines you're reading, Odell has its own fun, Odell has its own benefit, Odell has its own joy, that it trains you for your scenario-based questions situation there. So it will help you how to tackle the situation clinically. Guidelines are only applied, but Odell trains you to completely imagine those clinical situations. So when I discuss this case today from Odell, I would also be slightly taking you here and showing you that these are the important information in the guideline that you can follow. Excuse me. All right, so let's start with case number 31, which is, ouch, about your accidental exposures to bloodborne viruses. So you have sustained a substantial percutaneous injury to your foot. It has penetrated your skin. It is percutaneous injury, so it has penetrated your skin. What should you do now? So this is the accident happening here. It is stained in the blood, this elevator, and it has penetrated your skin, reached your vascularity. So you are extracting a difficult tooth and have used a luxator to loosen the tooth prior to elevation. While transferring the luxator to the table, you dropped it, and the luxator has impaled itself into your foot. So there is a penetrating injury now. What diseases of significance may be transferred by the injury? So most importantly, please remember, even your infection control guidelines say so. And these are the three major important viruses which are most prone to be transmitted through your dental practices, through accidental exposures. So these are your HIV, HCV, or HBV. These have the highest infectivity, and these are of most concern in your dental environment. So although your standard precautions, they take care of all three kinds of viruses, HIV, HCV, and HPV. When you sterilize your instruments and you follow your standard precautions, you're making sure that there is no transmission of these viruses. But through the penetrating injury, when the patient's blood penetrates your skin and enters your circulation, then yes, the chances of transmission are higher. So what diseases of significance are transferred? You have to remember they are the three: HBV, hepatitis C, and HIV. If the question gets asked about the three most commonly transmitted viral infections through your accidental procedures or exposures, they are your hepatitis B, hepatitis C, and HIV. And also, you must remember the rate of transmission of these three viruses. For HIV, it is 0.3%. For hepatitis C, it is 3%. For hepatitis B, it is 30%. Must remember the percentages also. What should you do immediately now that there is the entry of the patient's blood into your circulation? What should you do immediately? Encourage bleeding at the injury site, because that would promote whatever contaminated blood has entered your circulation. Maybe some of it can be removed if you encourage bleeding. And thus, if you remove that blood, the chances that viral load in your blood would be reduced. So the benefit of encouraging bleeding is if somehow patient's 1 ml blood entered your body, and if by encouraging bleeding, say about 0.6 or 0.5 ml got out through the bleeding. So by reducing the amount of blood into your body, you are reducing the viral load. And the chances of transmission, the guidelines say not to encourage bleeding. No, they say don't squeeze bleeding. You don't have to squeeze, or you don't have to force bleeding. You don't have to press it, but whatever naturally it goes out, it's not a problem. Okay, so you don't have to squeeze and press and kind of squeeze out the blood of your body. You don't have to do that. But yes, whatever naturally flows, because there is an injury now, whatever superficially the bleeding is induced, let it happen. Encourage bleeding, don't stop bleeding. That's what you mean by this term here. Yeah. So encourage bleeding, don't try to stop it, but don't also try to squeeze blood out of your body. That's all it means. Yeah. Encourage bleeding, because so that some of the blood may go out and may reduce viral load. Wash it with soap and water, but without scrubbing the wound. Antiseptics should not be used because their effects on the local defense mechanisms are unknown. Free bleeding should be initially encouraged. But yes, don't let the patient bleed out also. If it's a deep injury, you're not letting him die out of bleeding, right? What is the most urgent priority and why? So the most urgent priority is to assess whether there is a significant risk of transmission of bloodborne virus infection or not. If you have gotten a patient's blood into your circulation, the risk of transmission would be higher if the patient is suspected to carry one of these viruses or more of these viruses, right? Hepatitis B, then hepatitis C. So the risk of transmission would be higher if the patient's blood has all this. If the patient's blood doesn't have any of these three, then no matter how deep that penetrating that injury is, you're not at the risk of getting the infection. That makes sense, right? To get the infection, you have to get the pathogen in your blood. And that risk assessment has to be performed, because you have to give a post-exposure prophylaxis in terms or in case of HIV risk. We'll talk about the management of HCV, hepatitis B, and HCV individually also. In infection control guideline also individually you'll find it. What should be the management if there is a risk of any of these viruses? In case of HIV, you have to start with post-exposure prophylaxis, which is done with antiretroviral drugs. It can significantly reduce the chances of transmission of HIV, but for maximum effectiveness, it should be given within the first 2 hours. The reduction in the risk of HIV transmission, if you timely give prophylactic antiretroviral drugs, is as high as 81%, and that's quite a lot. So please try to remember these values. I mean, not sure they would be asked in the exam, but it's good that if at all they get asked, you should keep these numbers handy, and they're not very difficult to memorize. There is some evidence that some protection of transmission is still possible, even if you administer a delayed PEP, and even by as much as 48 to 72 hours. But in the first 2 hours, the chances of reduction of transmission is by 81%. So how could you obtain your PEP if required? So of course, they have explained how you can obtain them in your UK department, but of course, definitely in each country, you have departments where you have to manage and report these accidental exposures, and then a formal risk assessment for each individual injury has to be performed. And this involves determining the severity of the injury, risk that the patient is carrying, HIV infection. So there are two musts, or two most suspicious events that needs to be taken place to suspect that there is a high risk of transmission. And what are those? So basically, to get an acquired infection from the patient through this accidental exposure is that patient blood must contain one of these pathogens, or at least patient must be at a higher risk of having them. And then the injury should be so severe that this blood has actually entered your circulation, right? So the procedure for obtaining a formal risk assessment varies with local circumstances. In hospitals, the infection control consultants, hospital casualty, or occupational health department will perform. Those in general practice can contact their local hospital departments, which will follow their local guidelines. Each dental practitioner should know the number of who to call when you have such accidental exposures. When you call them, you will be asked for the details of the injury and of the patient. You will be then told whether or not the injury carries a risk of transmission. Do you require PEP or not? To provide this information, you or a member of your team will need to carry out a risk assessment on the patient as well. So two things need to be judged. Is the patient is at risk, and is the injury deep or penetrating enough to cause you the infection if it was a positive source of infection, right? Like in ABP, you have been meeting two criteria, right? The cardiac condition and then the procedure which is done. Both have to meet to give you a positive outcome that ABP is required. Even if one of them is missing, you don't need ABP, right? So two criteria helping you judge that one event would be taking place or not. Similarly here, two criteria to help you that this event of PEP would be taking place or not. One, the patient's risk of having HIV, and the second is the injury being so severe that it can transmit that infection if it was positive. Does that make sense? So both need to be as a positive event for you to decide that whether PEP would be given or not. So what is the risk of developing HIV infection after sharp injury? This explains all the 3 percentages that I've already given you: 0.3 for HIV, 3% for HCV, and 3% for hepatitis B. What factors affect the risk of transmission? An increased risk of occupationally acquired HIV infection is associated with, first, it has to be a deep injury. So let's talk about the severity of the injury. I mean, you're saying that, okay, the person has to have a risk or carrying the infection. And the second is my injury has to be of that nature that it can actually favor the transmission. So let's see what is the criteria for that. It has to be a deep injury. It has to have visible blood on the instrument or device that actually led to that injury. You can't have a plain sterilized instrument or the instrument which actually did not come in contact with the patient's blood and then get an injury with that and expect it to transmit the infection. If it did not reach the patient's blood, there is no infection carrying blood on that instrument. And even if it penetrated you deeply, the instrument is not coming across with these blood-borne viruses. So it has to be deep, reaching a circulation, also carry a visible blood, which may contain that infectious agent. Then injury with a needle that has been in a blood vessel. So not all needle injuries or needle pricks which you have used for giving your local anesthesia, not all of them would be into blood circulation. And that's why not all needle injuries would require or would carry a risk of transmission. And plus the patient's viral load. Patient must be also in a state of the infection where the viral load is higher, the infectivity is higher. So all these affect the chances of getting the infection through that contaminated blood. Viral load is a measure of the concentration of virus in the blood. It is more so important in case of your HIV. It is higher in the period when there is window period, reduces with early infection, but then rises significantly with symptomatic and late stages. The risk from a needle stick injury, where the needle has been used to administer a local anesthesia, is therefore lower because needle would not be expected to be in a vessel or circulation if an aspiration technique was performed. But if you did not perform aspiration technique and you're not sure whether you injected it into the blood vessel or in circulation, and you cannot simply outright forget it because it was a local anesthetic needle stick injury. If you did not aspirate it, you don't know, it will have very well be in circulation and you may be at risk of acquiring it. Splashes of infected blood carry a low risk. So if it did not penetrate your skin through the instrument, but rather you got a splash of blood on your face. So if you got a splash on a broken skin, a cut or wound, or maybe your mucous membranes like your oral membrane or your eyes, then instead of getting the chances of transmission 0.3, it reduces to 0.1 through the mucous membranes and broken skin. If it's not penetrating injury, but rather splashes. And if the blood splashed only on your skin, intact skin, then the risk of transmission is nil. So your injury is a deep injury caused by a sharp instrument which was covered with blood. So there is a risk of transmission of HIV in case this patient had HIV. So as per the criteria of the injury, this injury supports your PEP. This injury supports the increased risk of transmission. The second criteria also needs to be judged, whether the patient carries the virus or not. Because no matter how supporting your nature of the injury is towards the risk of transmission, if there's no HIV in the patient's blood, you cannot get it. So the patient has returned to the waiting room with your nurse. What will you say and do? In a private area, you should explain to the patient exactly what has happened and that there has been an accident involving a surgical instrument. Inform the patient that there is a practice policy which is derived from the guidelines. Introducing the HIV assessment of the patient in this way will depersonalize the incident and avoids making difficult judgments, and patient would not perceive that they are being discriminated against if they were a high-risk group for HIV infection. Like a patient could be a homosexual, and if you're not generalizing this, he could totally take it like, because I'm a homosexual and homosexuals are at a high risk of getting HIV, so you're discriminating against them. So just tell them it's done for all patients, whoever has been involved with the clinician with these accidental exposures. Patients should be asked to give their informed consent for blood to be taken and tested for HIV, hepatitis B, and hepatitis C for storage of serum. Coming to that, what are the tests that you would be conducting on the patient's blood? And also, even your blood would be required. Even your blood would be required when you're taking your patient's blood sample. So let me just take you to this infection control guidelines. Do you see my switching screen? Do you see my Adobe now? Okay, great. So what are the tests that need to be conducted in your blood and the patient's blood, which will give you a baseline information? So baseline test is on the day of the exposure when you take the sample from the injured staff member and the patient. So the source and your injured staff member, whether that's clinician or assistant. So your blood, who's got the accidental exposure, should be tested for HIV antibody, HCV antibody, and antibody to hepatitis B surface antigen. So your blood, you can remember it like this, your blood is being tested for 3 antibodies only. 3 antibodies. There's no antigen that you're testing here, right? Please notice there's no antigen that you're testing for the patient or the person who has gotten the exposure. HIV antibody would indicate whether you were already infected with HIV or not before this exposure happened, right? So that you cannot claim that the person has given it to you. Maybe you already had it. Then HCV antibody also indicates your HCV infection or a carrier stage. And HCV antibodies indicate an active HCV infection or a carrier stage. So whether you already have HCV or not, that would be rectified from HCV antibody. So please mark it. HIV antibody and HCV antibody indicate your level of infection. Antibodies to hepatitis B indicate your immunity and not your infection, because anti-HDS, antibodies to surface antigen, is indicative of immunity rather than infection. So first 2 tests are done to see whether you already had those infections, and antibody test to hepatitis B would indicate that whether you're immune to hepatitis B or not. Does that make sense for everyone? Would you remember this? 3 antibodies tested for this person who got the injury and meaning of those tests. Coming to the source, the patient from whom the blood has been gotten into your circulation should be tested for HIV antibody, HCV antibody, same like your blood, which indicates infection. And only in the case of hepatitis B now, it would be changed to the surface antigen instead of antibody. In your body, they were testing for antibodies to see whether you got the immunity or not. And in the patient's blood, they would be testing for a surface antigen, which would indicate whether the patient has infection or not. Does that make sense for everyone now? So only hepatitis B test changed for the patient and the clinician. The source needs to be tested in case of hepatitis B for surface antigen, which indicates infectivity, and your blood, what the injury, should be tested for the immunity to hepatitis B, whether you're safe or not. Does that make sense? Will you be able to remember this? If at all the question comes, you would never be able to forget this. You should never forget this. What tests need to be done, you must know, right? So, if the patient has an undiagnosed HIV infection or hepatitis, then an earlier diagnosis is more likely to lead to an effective treatment for him also, and the dentist can also have the most effective prophylaxis to prevent infection in their body. Most patients are usually happy to give a sample of their blood under these circumstances. If not, then the reason for the refusal should be explored as sensitively as possible. It may be that patients have an impression that they have in some way done something illegal or hold a false belief about the virus itself. The general population has little knowledge of hepatitis, but many understand that it's a serious disease and may be aware that it can be transmitted sexually. At a minimum, blood should be obtained to source serum in case testing is required at a later stage. Dentists will most likely not have the facilities to take the blood, and the patient can be asked to go to a local hospital to get that done. The possibility that the patient might be having HIV will have to be addressed to assess the risk of transmission. This must be done in a sensitive manner, preferably in a private room, and with reassurance about the confidentiality of any answers that are given. See, one situation is patient either has it or doesn't have it. Then the other situation is patient might be in window period. So he might not have it right now, but he might be at the risk of having it, and he also might be in a window period, which would show up in about 3 months, right? So why are we asking him the questions which puts him at risk of acquiring HIV? Because in the last few months, if he has had those experiences, he might be in the window period. Does that make sense also for everyone? So not immediate every negative test would mean that the patient doesn't have risk of having HIV. He can very well be in window period. And if you ignored taking PEP at this stage, considering that he was negative, can actually lead to transmission of the infection. Is that correct? Lama, I'm going to talk about antibodies and everything, antigens and surface, etc. Let's wait for that. For now, do you understand the relevance of asking the patients of high risk chances of having the HIV at a higher risk? Yes, because he could be in window period and you can acquire it without even being evident on the blood picture. So these questions should not be asked by the recipient of injury because it is difficult to be objective when you're feeling anxious or distressed. However, in dental practice, there may be no other person suitable to handle the situation, and you may have to ask the questions yourself as well. As an alternative, you can consider somebody who's a specialist in it, and they can talk to the patient and then consider whether they're at high risk or not. So there are certain factors, risk factors, which put the patients at a higher risk. And these are these. They're about your blood donation, sexual activities, drug activities, and other IV exposures. So you have to ask all these questions. Being in areas where the HIV prevalence is higher, all these questions need to get asked to the patient. Everything about whether they've donated blood, whether they've been refused, whether they have lived in a place, whether they've had unprotected sex, whether they have used injected drugs, shared needles with people, all those things put the patient at a high risk. A positive answer to any of these questions requires further questioning to understand the degree of risk. And the risk factors for HIV are your parenteral infection and sexually transmitted. So parenterally, it comes through blood transfusions. Hemophilic patients also require transfusions. In drug users who use injected drugs, needle stick injuries, and then sexually transmitted also. So these are the two major risk factors for acquiring HIV. In practice, asking these questions does not usually constitute a problem because in almost all cases, there will be either no risk or very low risk. Similarly, most HIV positive individuals, they would readily tell you that yes, they are HIV positive and that you need to take a PEP. Only situation is where the patient thinks that they are negative, but you have to ask them these questions so that they may not be at the risk of being in a window period. What are the risk factors for contracting HIV infection? In the UK, in 2016, an estimated 54% of new diagnoses of HIV infection acquired through homosexuals were noticed. In contrast, the numbers of new infections acquired through heterosexual sex were 19% for men and 22% for women. So definitely homosexuality increases the risk of HIV. If the patient discloses that he or she is HIV positive, what information would you like to know and what is the significance of the answer? So yes, if at all, now then when the injury happened, there were certain aspects of the injury which you needed to know, how deep it is, what is the viral load, and did it contain the blood or not. So all those criteria of the injury also was important for you to know. So let's talk about if the patient was HIV positive, then what would be the factors which would indicate that what factors in the patient's blood which contains HIV puts the patient at a higher risk of transmitting or at low risk. So whether they're generally well or not, because being asymptomatic would mean low viral load and lower infectivity. CD4 count, suppressed CD4 count would mean excessive advanced stage of the disease, and thus also would mean higher infectivity. Their viral load and when it was checked, a direct measure of infectivity, if the viral load is higher, infectivity is higher. And the names of any medications they're taking so that the same drugs should be avoided as prophylactic exposure, post-exposure prophylaxis if they are not being effective in the patient. Then whether the patient's medication has changed recently or not, so that if their HIV strain has become drug resistant, so what drug is being effective on them, must know. Then address of the patient's HIV clinic so that to contact for further information, obtain consent to do this, and respect the patient's confidentiality. So even a positive HIV patient needs to be asked about these certain risk factors. If the patient indicates that he or she is not HIV positive, but agrees to give an HIV test, can you carry it out? So yes, UK national guidelines for HIV testing say that it should be within the competence of the trained healthcare worker to obtain consent and conduct an HIV test. If you do not have the facilities, you can get it done in the hospital. So what is PEP and why not simply take the drugs regardless of the relative risk? Coming to your question, Lama, you just asked, right? Why not just simply take it? So what is PEP and why not simply take it? Why to get into all these assessments? Why to judge the patient's past history, sexual history, social history, drug history? Why to get into all those private matters? Well, PEP is a preventive treatment started immediately after exposure to an agent which causes infection. The regimes for PEP after exposure to HIV are complex ones. It's not a single drug that you have to pop and you're done. New drugs are being developed and knowledge is continually acquired about HIV and the emergence of drug-resistant strains. This, along with the desire to reduce the side effects of PEP to increase compliance, means that the regime for PEP is constantly under review. So while this article was written, the regime included combination of tenofovir and then ampicillin, lopinavir, and ritonavir. This is continued for 4 weeks. And the side effects of these drugs include nausea, diarrhea, dizziness, headache, muscle weakness, skin rash. And these effects can be debilitating. And automatic prophylaxis for every sharp injuries, that's why cannot be advocated. So you cannot put this the receiver of the injury at those debilitating side effects for 4 weeks just by the fact that they've gotten a sharp injury, and let's just take it. So Lama, I hope it's sorted out. Pregnancy, although is not an absolute contraindication, but the evidence for the safe use in pregnancy is still limited. What if the patient indicates a risk of HIV to you, but you cannot obtain a formal risk assessment within 1 hour? So patient says that, yes, I may be at risk of HIV. I have had such of those suspicious experiences in the past. So, but you have still not formally gotten a risk assessment from a specialist within 1 hour. Then you should not delay starting your PP because the patient has been giving you a positive indication. So PP is at most effective within the first few hours and preferably the first hour. So if the patient gives you a risk indication and you've not yet gotten a formal risk assessment, still go ahead with it. Do I have to give a blood sample for testing for my own blood? Yes. And what all needs to be tested? HIV antibody, HCV antibody, hepatitis B antibody. Because you may have to prove that you did not have any of the infections at the time of injury. If the patient is subsequently shown to have infection, you will be asked to provide a sample for testing 12 weeks after the injury because that would be your window period. If the patient's blood came out positive, then you have definitely gotten it or maybe gotten it, but only would be confirmed after 3 months of the window period. So again, after 12 weeks, you would be required to give your blood for the testing. What is the risk of transmission of hepatitis B through this injury? So this should be minimal. Although through such injuries, the risk of transmission of hepatitis B is higher than your HIV and HCV, 30%. But why it is still less? As per the infectivity of the virus, it's higher. But why still less clinicians acquire it or get it is because most of us practitioners are vaccinated against hepatitis B. And if the practitioner has a sufficient 100 milli international unit per ml antibodies to the vaccine, a single booster may be given after an inoculation injury. But this infection control guideline does not recommend that. Let's see what infection control has to say about your hepatitis B antibody status, whether you have them or you have them less than required or you have them optimally. So levels of antibodies are really important when you have to judge that whether you can acquire hepatitis B infection or not. Because your only immunity comes from hepatitis B surface antibodies. Because there are different antigens in hepatitis B releases surface antigen, core antigen, and E antigen. Somebody asked that question, I think that was Lama. Yeah, why? What is the difference between normal antibody and surface antibody? So because hepatitis B has these 3 antigens, surface, E, and core. So each 3 antigen are producing 3 antibodies, right? I mean, individual antigen would release individual antibody in response to its own antigen. Amongst all 3 antibodies, surface antibody against surface antigen, E antibody against E antigen, core antibody against core antigen. So amongst these 3 antibodies which are released in the patient's blood in response to the antigens of hepatitis B virus, only the surface antibody indicates the immunity. E and core antibodies indicate infectivity and infection, just like your antigen. So that is why when you have to judge a person's immunity, you're not testing for E antibody or C antibody, but rather only S antibody, which denotes the immunity. Rest of the 2 other antibodies denotes infectivity. Is that clear now, Lama, and everyone else as well? Okay, perfect. So level of antibodies, which are your surface antibodies, is known or shown to be positive for hepatitis B surface antigen. So HBs antigen related antibody gives you the immunity. If the staff member is immune to HBV, then his anti-HBs antibodies has to be greater than 10. And then they're protected. But 10 to 100 is protected, although relatively low protection. I mean, they might not get a full-fledged infection, but they might not also be able to fight it really well on their own, and they might ultimately get it after fighting for a few days. And that's why a booster injection is prudent. So 10 to 100 is protection, but a weaker protection and definitely requires a booster injection. If the staff member is not immune, that means their antibody levels is going to be less than 10. Either they did not ever got an immunity by vaccination or by naturally acquired immunity by getting a past infection, or they got vaccination but they did not seroconvert. That means their blood did not form antibodies. And those people who do not develop antibodies against the vaccine are called non-responders or non-respondents. Or they have less than 10 international unit ml. So less than 10 or 0 antibodies because they did not respond to the vaccine all indicate that they're not immune. And if the person is not immune and they got the infection, contaminated blood, then they require single dose of hepatitis B immunoglobulin, HBIG. These are your immunoglobulins against hepatitis B, and these are, you can take them as your external antibodies. You're treating them with antibodies by providing specific hepatitis B immunoglobulin, and a single IV dose is given within 48 to 72 hours, so it is able to fight that current infection. But still, the single dose of immunoglobulin does not give you a lifetime protection. It will only prevent this time infection. Next time you get an exposure and you haven't had any vaccination before that, it's not going to give you a lifetime protection. It's only protection for this exposure. Yes, does between 10 and 100 means more than 10? Yes, Parvati. Simple, right? 10 and 100 is more than 10. Start a course of HBV immunization. So after you've given this immunoglobulin for current protection, but make sure that they're protected for the further future also by starting their vaccination. And then vaccination should be given within 7 days of exposure and then repeated at 1 to 2 months and then again at 6 months. So there are different protocols for hepatitis B vaccination, 013 and 016, both are accepted. Following the final vaccination, then you check the patient's level of immunity 2 to 4 weeks after the last dose, whether the antibodies have developed or not. Again, the criteria would be if the antibodies developed in the patient's serum is less than 10, they would be considered non-immune or non-respondents. And if they develop antibodies between 10 to 100, they would be protected but insufficient and give them a booster dose. And if they get the antibodies more than 100, they are immune, leave them as is. Does that make sense for everyone so far? Is it making sense? Is it helping you understand the entire HBV and every criteria about these bloodborne viruses a little more easier? So you understood everything about hepatitis B, right? So non-responders will receive anti-hepatitis B immunoglobulin, right? And if recent evidence of the effectiveness of the recipient's vaccination is not available, check their blood for antibody titer, then manage them according to less than 10, 10 to 100, and more than 100. If the recipient is not immune, then the risk of transmission is 30%, especially if the patient is E antigen positive. I'll talk about the antigens and their relevance also in a while. Then infection can follow transmission even from 1.1 ml of blood. Hepatitis B is so infective. Hepatitis B is so infectious that the degree of injury is almost immaterial. It is unlikely event that a non-immunized individual receives a sharp injury Specific hepatitis B immunoglobulin provides passive immunity, can give immediate but temporary protection. So hepatitis B immunoglobulin gives temporary but immediate protection after that accidental inoculation. But for the later future protection, you have to also start within 7 days your vaccination protocol. Remember that? Understood that? Easy? So does this mean I have to give blood even if I know that hepatitis B vaccination is successful? Yes, because whether it's in 10 to 100 or more than 100, you must know that. And that's why your HBs antibody was tested as a baseline test. Everyone remembers that? We tested HBs antibody? PEP is only for HIV, yes. PEP, we have had all that PEP discussion for HIV only, not for hepatitis B. So how can we determine whether the patient is infectious for hepatitis B? Then we are checking the patient's blood for hepatitis B antigens. Remember the infection control guideline that I showed you? For the patient or the source of blood, for hepatitis B, you're checking for the antigen, surface antigen. If that comes positive, also check for E antigen, because that would indicate higher infectivity. Coming to that in a while. What's the risk of contracting hepatitis C? The risk of contracting hepatitis C through a needle stick injury is 3% if the donor is infected. The risk is therefore higher than for HIV infection. But as for HIV infection, it is dependent on the amount of virus. So viral load is relevant for C. It is 3%, HIV is 0.3%, hepatitis B 30%. The consequences can be severe. As many as 75% of individuals who can get infected with hepatitis C will ultimately become chronic carriers, and out of the chronic carriers, 20% will develop serious consequences like cirrhosis, liver cancer, liver failure. It is estimated that 4,000 individuals in England are infected with hepatitis C. The majority remains undiagnosed. Prevalence of hepatitis C is higher in IV drug users, and that's between 3 to 42%. Is your prophylaxis available against hepatitis C? So protection against hepatitis B comes through vaccination. If there was no vaccination, then it also has an immunoglobulin available, which actually immediately takes care. What about hepatitis C? Hepatitis C, no vaccination or prophylactic drug is available, but it comes with a cure. There is a drug, there is a cure for hepatitis C. So a treatment is available if you get hepatitis C. If you get hepatitis C, then you will have to start early treatment, and it can prevent chronic hepatitis C infection and can prevent those serious implications. So let's talk about the antigens and antibodies and what are their significance. So hepatitis B surface antigen, hepatitis B C antigen, hepatitis B E antigen. First, let's talk about the 3 antigens. So they are the antigens. Hepatitis surface antigen indicates, when seen in the body, that there has been a past infection and current infection, but it may not indicate necessarily higher infectivity. So it is usually detectable in late incubation and during the acute stage of infection, but it declines after 3 to 6 months of acute infection. But if the patient becomes carrier, then it persists in them, so also linked with past infection, and whether asymptomatic or with chronic active hepatitis. Basically, takeaway point from here is surface antigen means infectivity, but not necessarily higher. Core antigen is never detected in blood, only present in liver, so not used for determining infectivity. E antigen indicates infection and a higher infection, state of infectivity. So surface is infection, but not necessarily high infectivity. E antigen is infection and higher infectivity too. Core is never detected in blood, only present in liver, not used for testing your infectivity statuses. Then talking about the 3 antibodies, surface antibody, core antibody, and E antibody. Surface antibody, I'm sure now by now everyone understands, it reflects immunity. So it indicates that there is no risk of infection because they have the immunity. It indicates that the patient either has had a past hepatitis B infection and now they carry the natural antibody. It is an acquired immunity because of the past infection. Or this was induced by vaccination, that's your active vaccination, active immunity. And that's why it would not have a risk of getting infection. And there is no need to further investigate to determine infectivity. Core antibody. Core antibody indicates past infection, and a high level would indicate that there is infection risk. So as I said, core and E antigen antibodies, core antibody and E antibodies indicates infection. S antibody indicates immunity. So only this one is used for testing immunity. Is it making sense for everyone so far? Nothing difficult? E and core antibodies indicates past infection and infection risk. E antibody also indicates either recovery or a carrier state with low infectivity. So both indicate some amount of infectivity. And surface antibody indicates immunity. Everything clear? Everything? All good? Okay, perfect. How can the risk of needle stick or sharp injury in the dental setting be minimized? Sharp injuries do not always result from needles. Burrs, hand instruments, and other contaminated sharps are all constitute a risk, and you should utilize sharp, safe devices such as your safety needle and scalpel systems. That have inbuilt covers which protects the needle point or blade after use. This legislation requires clinicians to risk assess of non-safety sharps used in their practice, replace with safer sharps alternatives. Ensure that the entire team is trained in disposal of sharps. Identify and dispose the needle and other sharps immediately after use. Always pass the instruments with the sharp end pointing away from the person. Remove burrs and ultrasonic tips from the handpieces immediately after use. Pick up your instruments individually. Retract the patient's cheek with a mirror while administering LA. Never you resheath the needle, holding the sheath in the hand, and then it can lead to risk of needle stick injury. So you either use a sharp safe device. If not available, use a one-hand technique to sheath the needle. Never place your finger or your assistant's finger in front of a sharp instrument, such as scalpel or laxator. Always use a firm finger rest when scaling. Dispose it into a solid container. Ensure that they are disposed of by incineration and by an authorized person registered to collect such waste. Use heavy-duty gloves when cleaning instruments prior to autoclaving. Keep your working area well organized and uncluttered so that such accidents are prevented. Always wear appropriate masks, visors, protective eye protection. Modern minimalist designer glasses, they will offer only little protection. Footwear should cover the top of the foot. If this particular clinician was wearing inappropriate footwear, this could have been altogether avoided. So what's your last duty before you can turn back on this unfortunate episode? You must remember to fill the incident report as required by the law, submit it to your employer. If the CO conversion occurs, you will need to inform some departments. This will be important evidence for industrial injury benefit or insurance purposes, together with the records in your notes. This injury has now ruined your day. This has all proved so complex. Why not next time you just might wash it off and ignore the injury? Why not? The main reason to worry that you might contract a bloodborne virus infection from an unsuspected carrier. The effectiveness of PP is up to 80%, which cannot be and should not be ignored. Also, it would be unethical for not to follow the possibility of developing an infection because you can jeopardize your own sexual partner's health with that. That's why must be acknowledged, must be addressed in the recommended guided method, right? So I hope the relevance of all the hepatitis B antigens and the antibodies made sense. The baseline test for you and the patient, which was the source of the blood, is making sense. You understand the percentages of risk of acquiring these 3 viruses is understood. How should you manage if the patient's blood was hepatitis B positive? And now what would you assess in the receiver's blood? and then take the next step based on the antibodies against hepatitis B surface antigen. Did that make sense for everyone? These were the main takeaway points. So that's why I said whenever you're reading this chapter, read it with infection control guidelines. It's a beautiful, technical, well understood and well applied concept. There is nothing that you have to mug up. If you just try to read it and understand the relevance of each and every step, it all makes sense technically very beautifully. But if you try to mug up all this information, you can't retain it. But if you look at the technicalities of the reasons why you're doing everything that you're doing, it all makes sense. Does it not? Was it confusing for anyone before and now has given some perspective? Okay, perfect. So can we take now some 10 minutes and get back to case number 32, a swollen face and pericorditis, where we'll be dealing about submandibular space infection. Let's take a 10 minutes. I'll see you guys in 10 minutes exactly from now. Okay. All right, so let's resume. And now we're going to start with case number 32. It is about the swollen face and pericorditis. Please remember, swollen faces, swollen facial infections, facial spaces, pericorditis, third molar infections, your deep space infections, your superficial space infections, they're extremely relevant and gets asked in your oral surgery relevant and your PG relevant papers in the exam. And in fact, you have amazing help in understanding these cases, in understanding these conditions in TG. TG has simplified it, beautifully targeted them, and given you a perfect guideline. And yet here again, apply the time to apply those guidelines to a clinical situation, as I've been referring, how TG and Odell can be married together, and you can get an amazing outcome and understanding through both of them. So when you learn TG and you apply that on your Odell clinical situations, you're basically enhancing your understanding of how to apply the guidelines to a clinical situation, because all the authorities are giving you guidelines. But just by learning guidelines, you cannot anticipate how you're going to manage a patient. And Odell gives you that confidence as well. It almost covers most of the commonest conditions that you might face as a general dentist, and be prepared for a clinical situation by applying appropriate recommended protocols and guidelines. And that's what you're being judged on when you go and take the exam. So I think there is nothing better combination that can train you for the exam more than this TG and Odell combination, right? I hope everybody is getting to also understand the relevance. You will understand the relevance more when we reach the stage of solving SBQs. Right now, you're learning all these clinical situations and its handling through Odell. When you reach the stage of solving SBQs, you cannot even imagine the ease that you will feel after having gone through these cases, learn to apply the conditions and guidelines on the cases. So the ease that you will feel once you start solving SBQs, and that's why this methodology. And that's why this methodology of not jumping straight away to SBQs and knowing the right answer. Rather taking each SBQ as a case, as a challenge, as a situation, and having that natural understanding of coming to the best answer, right? And that's what you're achieving and aiming here for. So please don't lose your sight from the target when you're following this approach of preparing the clinical situation and having the hang of understanding all the clinical situations, knowing the history and investigation part, coming to the different diagnosis part, knowing the management part, applying the technical guidelines that come with the same concept. So you are not even realizing when you're studying these chapters, when you're studying this by this method, the skill that you're developing to master SBQs. You just wait for another month and you will be surprised how skillful you feel when you come to those. So it's about a 23-year-old woman presenting to your hospital accident and emergency department with a painful swelling in the right side of the face and neck. What's the cause and what treatment would you provide? So please notice that here the patient is already presenting to the emergency department of the hospital and not to the general dentist. Well, this could have presented to a general dentist also. So we come to the management point and what happens and what should be done if it was presenting to a general dentist. There would be another beautiful case number 49, which would include buccal space infection. And why that case is far more superior to this one is because that also talks about different kinds of inflammations. When the facial spaces get involved, they could be edema, they could be your simple swelling, or it could be your cellulitis. So how to differentiate between edema, abscess, and cellulitis, that would be covered in that case. It would talk about superficial buccal space infection. Here we're talking about submandibular infection. So let me just bring into your perspective one important change that has happened in new TG versus the old one, is that old TG gives you the management of these spaces involvement by the criteria of deep space versus superficial space, right? By the criteria of deep and superficial space, the old TG is teaching you how to tackle these facial spaces infection by the basis of these two categories of spaces. The new TG, however, has changed its management perspective by rather than focusing on the space involved, but what is this rapidity and extent of the involvement. If it is spreading, they use two words which are extremely important, spreading and systemic signs. So if it is a spreading swelling and systemic signs are involved, that would involve similar management like your superficial, like your deep space infection, which was earlier mentioned. And if it is not spreading and systemic, but is only a facial swelling, but there is not a sign of spread or systemic involvement, then you only manage it by your oral antibiotics. Spreading and systemic would require your IV and antibiotics requirement. Even your non-spreading and systemic infections in certain cases have been dealt with, no antibiotics at all also in certain situations. But I'm not trying to compare both of them right now. I'm not trying to even go in details of what new TG has to offer. So far, the ADC does not recommend reading the new TG edition, that they would be taking questions from the new TG. Till the time ADC doesn't announce that, we don't care what is the new recommendation. Because yes, you care as a dentist when you're practicing there, but not till the time you're taking the exam, which is following the older recommendations only for now. So for this chapter and for case 49 also, we would focus our concerns and managements as per your deep space and superficial space involvement. Superficial spaces are your infraorbital spaces, buccal space, mostly related to your maxilla. Deep space infections are your neck spaces, sublingual, submentals, and submandibular, retropharyngeal, your parapharyngeal. Those spaces which has direct communication with the respiratory spaces are your deep space infections. Superficial do not have direct connection with the respiratory spaces and thus are called superficial. Although superficial infections also come with fatalities and fatal consequences, but they are rare and can be avoided even with oral antibiotics. But deep space infections being very rapid in spreading potential does require immediate hospitalization and IV management. This is the broad takeaway of superficial and deep space infection. Did that make sense for everybody so far? We are not, even in your discussion groups, you're not going to create a contrast between the new and old TG. Please, you will confuse your peers, you'll confuse your friends. I totally request you not to draw parallels, not to compare. Because it is not asked, let's leave it for a while. The patient has suffered worsening pain from their wisdom tooth on the lower right side for 5 days. There has been some swelling of the gingiva around the tooth, and she has been unable to bite her teeth together for a few days. Yesterday, she noticed the pain in floor of her mouth and found that moving her tongue was also painful. Today, she woke to a facial swelling. She feels unwell, has difficulty eating, swallowing, opening her mouth. So, there's been swelling around gingiva, and then she was unable to bite in that area. Then she got pain in her floor of mouth. Tongue movement was difficult. Then she developed a facial swelling involving below the angle of the mandible, below the lower border of the mandible. She feels unwell, so she has developed systemic signs. She has difficulty eating, swallowing, opening, trismus. Do you focus on all the relevant signs and symptoms that she's coming and presenting with? Is it easier, clear, and you understand, right? Each sign has its relevance. She has had an episode of pericorditis a few months ago also, so it's a recurrent pericorditis episode. She was on a waiting list to get all her molars extracted. Until the swelling developed, she thought this was just another attack from her wisdom tooth. She has never had facial swelling before and has come straight to hospital now. Patients otherwise fit in well. There's palpable tender lymph nodes in the upper deep cervical chain and submandibular triangle. Opening is limited. There is 15 mm in interincisal distance compared to normal, which is 44, so there's major trismus. There's swelling below and around the lower border and the angle of the mandible extending back towards the neck. Swelling is hot, tender, firm, dusky red color centrally, indicating cellulitis and rapid inflammation. Swelling is not pointing to the skin. There is marked keratosis, which is a very common sign of pericoronitis because there is food impaction up under that gingival pouch. Trismus is hampering your intraoral exam. The lower right third molar can be seen, partially erupted, operculum is swollen, pus is exuding below it. Second and third molar appears caries-free. Floor of the mouth is tender and firm on the right side, yet there is no swelling on the floor of the mouth yet, only tenderness and firmness. What additional examinations or investigations will you perform? Well, it is extremely important to take the patient's temperature to determine whether the infection is exerting any systemic side effects or not. Most importantly, so she is pyrexic, she has fever, there is systemic involvement. There is a need to confirm that pericoronitis has only caused this. It is also prudent to exclude that this swelling is not coming from other molar. And a test of vitality usually indicates that, but trismus would not maybe favor that. And radiograph would only be required if the vitality test came negative and you think that there could be a periapical lesion attached to that. Unless that is suspected, you do not require radiograph for now. What do these findings tell you? So there is combination of inflammation, swelling, pain, redness, heat, together with local lymph nodes involvement. Pus is exuding. It completely indicates infection. Pericoronitis is present, and this is the primary source of the infection. Trismus is an important sign which indicates that some of the muscle of mastication is involved. So the space where the infection has spread to is a masticatory space. Patient is pyrexic, elevated temperatures. It indicates that it is exerting a systemic effect. Infection appears to be spreading relatively fast because swelling has appeared overnight. There are already systemic signs. Which type of infection is this? So, of course, we will be talking about in details of the features and signs of edema, abscess, and cellulitis in case number 49. Beautifully describes that. All the doubts will be sorted. For now here, the rapid spread, firmness, and tenderness, and the brawny appearance indicates it's cellulitis. And locally, there is pericoronitis because gingiva is involved. Pus is draining under the operculum, which indicates a local abscess which is formed. But now that has spread to a space, which is usually by the location, looks like a submandibular space. And this is a cellulitis kind of swelling. And cellulitis is rapidly spreading. And it can also develop into an abscess. There is probably mixed infection, anaerobic microorganisms predominate in cellulitis. And it is also spreading and it involves respiratory spaces quickly. So to which space this infection can spread from the lower third molar, and what are the boundaries of this spaces? So if you look at the diagram here, this is your carotid artery, this is your parotid gland behind the mandible, this is the mandible ramus. Outside the mandible ramus, you have your masseter muscle. Inside your ramus, you have your medial pterygoid muscle. Then medial to your medial pterygoid muscle towards the throat, you can say you have superior constrictor of pharynx. Anteriorly, it meets with your buccinator muscle. The junction of superior constrictor and buccinator is called pterygomandibular raphe. If you remember that, we did a question in the last class. So these are your anatomical landmarks. And the spaces which can get involved is from the third molar, it can go to A. If it goes to A, if it stays above the mylohyoid muscle, it involves sublingual space. If it penetrates below the mylohyoid muscle, which is the floor of the mouth muscle, you involve the submandibular space. If it goes outside into E, between skin and buccinator muscle, it would be your buccal space. If it goes between medial pterygoid and superior constrictor, in between that, that's your parapharyngeal space. Because it is between your pharynx muscle and medial pterygoid, parapharyngeal space, that's your respiratory space. Between your medial pterygoid and mandible, it is your pterygomandibular space. Between the masseter and your mandibular ramus, it's your submasseteric, below the masseter, so submasseteric space. So for trismus to be happening, what are your masticatory muscles? Masseter is a masticatory muscle, medial pterygoid is a masticatory muscle, superior constrictor is maybe not a direct masticatory muscle, but yes, helps in swallowing. So this patient also has gotten some swallowing defect. So medial pterygoid and masseter both are your masticatory muscles, and so that's why if the submasseteric space is involved, pterygomandibular space gets involved, or parapharyngeal space gets involved. These three spaces involve both your masticatory muscles can give you trismus. This patient has trismus, so that means not just their submandibular space, which is evident here, there is some posterior space involvement as well. Do you all agree with that? Do you all understand that? Do you understand the names of the spaces? Easy. If you look at the muscles, not difficult. Don't ever try to get intimidated by all this anatomy, right? It's all very understandable. It's all simplified. Just need to focus on it. So these are the practical spaces where they might get spread to. It's given in the table here, which I have just explained you. All the sublingual, submandibular, parapharyngeal, infratemporal is just above your pterygomandibular space. Instead of going lower between your medial pterygoid and mandible, it is also between your mandible and medial pterygoid, but superiorly. So infratemporal space gets involved if the infection spreads superiorly rather than inferiorly. Similar boundaries. Submasseteric space between the masseter and the ramus of the mandible, buccal space between the skin and the buccinator muscle. You just take all these landmarks and these space involvements. So these are your possible space involvements, possible with the third molar involvement. Now, in what tissue spaces is the present infection tracking and why? So you know all the possibilities. Let's come to the definement of where this patient is having infection. This appears to be clinically on the facial space into the submandibular space because of the area involved. The main infected tissue is not visible and lies around the submandibular gland deep to the body of the mandible. Swelling is spreading around the lower border of the mandible onto the face. Also, it's coming up. Moderate trismus is typical. It is relatively common for this tissue space to be involved in pericoronitis. There may well also be early sublingual space involvement because she complains that there is firmness and pain in the floor of the mouth, and also tongue movement is slightly affected. So there is early space involvement in sublingual, but not completely because there is no evident swelling yet. Infection can readily track between your submandibular and sublingual spaces around the submandibular gland because they're only separated by mylohyoid muscle. If the infection penetrates through the muscle, these two spaces can immediately contact. So there is not yet an established sublingual space infection because this would cause an extensive swelling of the floor of the mouth and can completely limit any movement of the tongue. But swelling from the sublingual space infection is also readily visible in your sulcus and causes considerable edema because the floor of the mouth is very stretchy and loose. So you can immediately have all the exudate distending that tissue there. And that would be readily appreciated in the patient mouth, which is not evident yet. That's why they're calling it an early involvement, not a readily complete involvement. Then pus from the lower third molars tend to perforate the lingual plate more than they penetrate the buccal plate because it is closer and thinner. Infection is deflected to either, if it is present, if the roots are present above mylohyoid, it would involve sublingual. If it's present below the mylohyoid muscle, then it will spread into the submandibular. So is this potentially a life-threatening infection? No, not yet, but it is serious. Patient's airway is at risk if, because it's cellulitis, it can spread posteriorly. This would be potentially fatal if respiratory space gets involved. Dyspnea can develop unexpectedly and with great rapidity. Vigorous treatment of the infection must be commenced immediately. What is Ludwig's angina? Is this a risk? Well, Ludwig's angina is a bilateral infection involving the submandibular and sublingual spaces. It is frequently caused by cellulitis only, just like in this case, but rather bilaterally spread. Spread of infection involves epiglottis, parapharyngeal spaces, immediately causing you airway obstruction. Death can result from spreading infection in the body, disseminated intravascular coagulation, spread into the facial planes, into the mediastinum, completely blocking your airways. Early diagnosis, prompt surgical intervention combined with definite airway management. They are absolutely necessary to prevent any morbidity or mortality. Is there a risk that the patient might develop this condition? This particular patient? Well, it would be possible for this patient's condition to progress into Ludwig's angina, but this is not likely to be imminent effect or imminently immediately seen. And any treatment you can start at this point will prevent this Ludwig's angina to establish. But she could still develop airway problems because still one submandibular space is involved and it can involve parapharyngeal spaces. The principles of treatment of odontogenic soft tissue infections are given in case 49. But rather, I would say, even in case 49, whatever indications they're giving, you have to follow nothing more than what TG has to say about management of deep space and superficial space. Don't get confused in what Odell has to say about the treatment part. Treatment part is absolutely important and sufficiently given in your TG. Can I just briefly read that so that that also gets brushed up? Because I'm sure all of you must have read it once. So treatment for deep spaces and superficial spaces. You can see that it has categorized it. Can you all see my screen? Superficial infections and deep space infections. Let me just focus on deep space infection today. So odontogenic infections which spread to submandibular and pharyngeal spaces are potentially life-threatening and there's a risk of airway obstruction. Any patient who's got trismus cannot open their mouth more than 2 centimeters. That is 20 mm. This patient has 15 mm. Must be assessed for signs of airway compromise. Signs and symptoms of airway compromise include stridor, dyspnea, dysphagia, elevation and firmness of the tongue. Patients with deep space infections and a compromised airway must be assessed urgently by an oral maxillofacial surgeon and other surgical and anesthetic specialists in the management of such patients. Prescription of antibiotics without active dental treatment and referral is not appropriate. So patient with systemic symptoms of pain and dehydration needs to be managed in hospital. So this patient had fever, needs to be sent to hospital. Particularly if the infection is extensive, management would involve active dental treatment and antibiotic therapy through IV route. So drainage and removal of the tooth would be active dental treatment. You take culture and susceptibility for targeting the antibiotic therapy, and then IV fluid therapy and antibiotics. And the preferred antibiotics are because it is predominantly anaerobic infection, as I mentioned, metronidazole along with other amoxicillin. So penicillin and metronidazole, either benzyl penicillin or amoxicillin or ampicillin, along with metronidazole. And substitute the patients who have sensitivity to penicillin with either your cephalosporins if they give you the history of delayed hypersensitivity, but if they give you immediate hypersensitivity history, then clindamycin or lipomycin, right? So follow the IV regime along with active dental treatment in the hospital admission for such deep space involvement. Is that clear for everyone? And that is your treatment here. So where this patient be treated? Hospital, agreed, TG approved. Is pus present? How will you drain it? Well, it is unclear at this stage of infection whether an accumulation of and antibiotic therapy through IV route. So drainage and removal of the tooth would be active dental treatment. You take culture and susceptibility for targeting the antibiotic therapy, and then IV fluid therapy and antibiotics. And the preferred antibiotics are because it is predominantly anaerobic infection, as I mentioned, metronidazole along with other amoxicillin. So penicillin and metronidazole, either benzyl penicillin or amoxicillin or ampicillin, along with metronidazole. And substitute the patients who have sensitivity to penicillin with either your cephalosporins if they give you the history of delayed hypersensitivity, but if they give you immediate hypersensitivity history, then clindamycin or lipomycin, right? So follow the IV regime along with active dental treatment in hospital admission for such deep space involvement. Is that clear for everyone? And that is your treatment here. So where this patient be treated? Hospital, agreed, TG approved. Is pus present? How will you drain it? Well, it is unclear at this stage of infection whether an accumulation of pus as well as cellulitis is present in submandibular space. Because drainage is also part of the treatment, it should be done. Infection at less important sites might be treated with vigorous antibiotic therapy and removal of the cause, followed by drainage if required. However, because of the proximity of the airway, incision must be performed if there is suspicion of abscess formation. Even with cellulitis, there is some small space abscesses and collection of pusses. Drainage is a safer option in this case. Submandibular space must be drained through an external incision on the skin, ideally 2 centimeters below the lower border of the mandible, to prevent damage to the mandibular branch of your facial nerve. In practice, they may not be appropriate site, and a soft spot centrally in the hard swelling is the best place to incise. Distortion of soft tissue makes the positioning of the nerve difficult to predict. Forceps should extend up medially to the mandible to drain the space. A drain put there to let the area drain for continuous days, 1 or 2 days, should be placed there. Drainage of the sublingual space is not indicated in this case and is rarely necessary. It could be achieved when required via an incision in the floor of the mouth, but avoiding any damage to the lingual nerve. Pus should be released from pericorneal tissues through either an intral incision or by direct extraction of the tooth. So yes, drainage and extraction of the tooth, again, TG approved management. How will you then remove the cause? Tooth removal may require GA. It would be required to even drain the swelling also. Fiber optic guided intubation may be necessary because of trismus and infection around the airway. In a more advanced case where airway has already been involved and is edematous, intubation of a conscious patient may be required because after GA, there would be paralysis and then intubation would be difficult. Perforation of the pharynx during intubation is also possible if it is edematous or swollen and displaced. And this can also, if you perforate pharynx, you're actually incising that pharynx and it's draining all that pus into your chest. So forcing the mouth open also might tear the membranes and spaces, and then also can lead to pus draining within the lung. It may well be possible to remove the third molar at the same time, despite the poor access also. This breaches the general surgical principle that surgery should be best avoided in an infected field. But with effective IV antibiotic treatment, post-op complications are rare. Obviously, your decision will depend on the difficulty of extraction. Removal of the opposing third molar can also speed recovery, reduce the chances of another episode of pericornitis. And the removal of the lower third molar may have to await resolution of infection. But as per TG, active dental treatment, drainage and extraction should be part of the treatment. So we will not follow this advice, but rather stick with this one, that with good antibiotics, post-op complications can be nil to minimal. So drainage, removal of the tooth, IV management through antibiotics and hydration. And then would you provide antibiotics? Where? Well, very well. We have read the antibiotics needed, that is metronidazole, plus amoxicillin or ampicillin or benzyl penicillin. So that gives you a broad spectrum coverage of both gram-positive as well as anaerobic bacteria. So yes, prescription of antibiotics is required. Metronidazole along with penicillin, that is your recommendation. Based on the penicillin allergies, you may substitute with cefazolin or your clindamycin. So coming to summarize this too, this patient presents with a deep space infection. Let's summarize only that today. So there are possible extents to deep space infections, which is your various spaces like your buccal space, sublingual, submandibular, parapharyngeal, pterygomandibular, submasotric, infratemporal. So various spaces where deep space infection can progress, and your interincisal opening indicates trismus if there is restricted interincisal opening. Although signs and symptoms of brawny swelling, red, hot, temperature, rapid inflammation, systemic involvement indicate cellulitis. Cellulitis present in deep space infection calls for hospital management, required treatment by drainage, extraction, and your IV hydration and antibiotic therapy. All that must be assessed and done immediately to prevent any serious fatal consequences. So that's about your management of deep space infections. We'll talk about the management of buccal space infections when we come to that case 49. As I told you, that's also a very informative case. Yes, absolutely. All the doses given in the TG are absolutely important because ADC is known to give you questions based on the doses of the drugs as well. They'll give you various regimes and they'll ask you the correct or the incorrect one. So you must be able to identify the correct regimes. So I'm not asking you to go beyond TG, but within TG, whatever regimes are given, and they're mostly repeats, Lama. Mostly repeats. So you should not have difficulty. What I recommend is if you're done reading TG, from all the chapters, like you have antibiotic regimes in salivary infections, you have antibiotic regimes in ADP chapter, then you have salivary antibiotic regimes in this space infections, deep space and superficial space. You have also antibiotic regimes in case of your surgical antibiotic, I think. So let me just go to this chapter. Yep, so you have recommendation of antibiotics here. Yeah, odontogenic and salivary gland infections, ADP chapter, and then you have for your salivary and odontogenic spaces are here together. So these are the three antibiotic regimes that you have to memorize. Then you have to also remember the drug doses of paracetamol, aspirin, codeine, all those required for pain. Then you have to remember doses for local anesthesia, the per kg body weight recommendation of all the LAs. Then anxiolysis, sedation, so BDCs doses that you must remember. And then you must remember the doses for the emergency drugs, like your aspirin, like your glyceride, trinitrate, right? So those are your drugs, adrenaline. So these are your drugs, emergency drugs. So these are your basic, sum of all the possible regimes that are given to you in the TG. Now my recommendation is, yes, adding to that, or mucosal diseases, your steroids and your apis ulcers, etc. doses, all those. So coming to that, all those drug regimes, what to do with those? So what you can do is maybe take a good sticky note or maybe a chart paper and just beautifully write down these regimes. Give a heading, and you don't have to put down all the regimes together. You can make separate regimes in different papers and slips, and maybe just for a few days keep one chapter regime there on your fridge, on your maybe bathroom mirror. So any place that you visit a lot in the day, usually would be your fridge or your bathroom mirror, or your dressing where you like dress up or your change. So there are your corners, like favorite corners in your house where you go frequently. Put them there so that you're looking at them 2-3 times a day or maybe even more. So you don't even have to make an effort memorizing it. Just look at it, just read it, and okay, don't make an effort, right? It's a low effort, high benefit task. So you just maybe you're brushing your teeth and you're looking at that, sorted. So if you do keep repeatedly looking at that, by the exam time comes, you would be never forgetting these regimes. So if you have to memorize certain things which confuse you, this is your technique. You can apply that to any facts that you have to remember. You can keep changing your notes, you can keep changing your slips, you can keep changing the post-its, but keep looking at it frequently wherever you're having difficulty in memorizing stuff. So what you would achieve by this is you would not even make an effort and still memorize a lot of good points. So you would not have to open a book and sulk about it that I have to memorize drug regime, but rather it would be like a casual movie watching, right? So try that. It works out amazingly. Helps you retain a lot of difficult facts, but in a very less effort kind of way, which doesn't stress you out. So you can keep changing. Every week you put something, then change it. Every week you put something and change it, and then try to recollect. Do you remember that or not? Most of the times you would be always saving that into your long-term memory. Right? So that was it for today. And I hope you guys could gather a lot about deep space infections and also about your blood-borne viruses, hepatitis B virus, hepatitis C, HIV, the risk factors, the PEP, the vaccinations, the antibodies levels, the immunoglobulins for hepatitis B. Great concepts, great insights to learn. I hope you all enjoyed. I hope you all gathered and it was informative for you. Please apply the ideas. Please revise the concepts. Please revise the guidelines of the cases together to get a beautiful gel so that it sticks with you for long. All right, so I'll see you guys on. Yeah, do we have to memorize space boundaries? No. I mean, it's good if you know it. It's good if you know it. Especially so many if you look at that diagram. I don't think if you look at that diagram wisely, You'll not forget it. So that's what I'm saying. If you cannot memorize, you can simply take a screenshot, take a printout of this diagram, stick it there. You look at it every day, you'll remember it. You cannot unsee it. If you know it's masseter, ramus, and then needle pterygoid, you can never forget it. So keep looking at it. This diagram is beautiful. I don't think you even need to remember any muscle name or any structure name if you just remember this diagram. Yes, please try on the mirrors and your fridges and wherever you spend most of the time, maybe in kitchen, on your cupboards, wherever, in your dressings, in your almirahs, in your wardrobes, anywhere that you just think that you open that drawer a lot, you put it there. It helps. It helps. You cannot avoid looking at it once you're accessing that that cabinet door multiple times. Try that. It's a fun way of learning without stressing yourself out. You're creating and you're just having fun with studying and learning. So that's how we love to do it here, and let's keep doing more of it. All right. So I'll see you guys on Wednesday. We do one Odell case again, and then more MCQs and perio. We're going to start perio. We'll finish perio by Friday, and then Saturday you get the quiz on perio.